So we're going to move on to our next speaker, who is a good colleague of mine, good friend, John Amuasi, who is, as well as his, you can look at the biographies, by the way, they're in the materials to find out more about each speaker. But as well as his the network that he's representing here, he is also a commissioner for the Lancet One Health Commission. So he really is an expert on One Health issues. So over to you, John.
Oh, thank you very much, Peter. I'm just going to start to share my slides from here. Let's all right. All right, just can you confirm that? Okay, good. And I'm just going to make this a full screen and we should be good to go. Lovely. So I'm just want to say thank you for having me on this morning. It's a real privilege and certainly a great opportunity to share some thoughts around One Health, which has become so topical in today's world, given the situations that we are in today. I wear a couple of hats, as Peter already mentioned, and you can see those there. I do have this picture right here, which is from the FND, the Finance and Development Bulletin of the IMF. It talks about policies, politics, and pandemics. It makes a really interesting read. It was published in June 2020. I do recommend for all who are interested in this. And I speak to the paradox of global policies for pandemic prediction and prevention. And really, we are fully aware of the burden of disease, particularly when they turn to epidemics. And in this situation, actually pandemics. Already Jono did speak to the impact that epidemics and pandemics have on the global economy, on the medical health systems, the social systems, and even just general development. And we are already really concerned about the backtracking that we would have to do with regard to our development plans because of the COVID-19 pandemic. Countries were just recovering, at least in West Africa, Guinea, Sierra Leone, Liberia, from the Ebola epidemic, only now to be hit with COVID-19. Of course, a bit more used to it, so the various measures that need to be put in place were put in place pretty quick. Guinea is again suffering from another wave of Ebola, for which vaccination actually started this week. So we have to grapple with vaccination for Ebola and then for COVID. So it really is a dire situation, a real huge burden. I want to also make a quick mention of what I call the double whammy of COVID-19 and poverty-related diseases. Now, it's about just the layering of this zoonotic disease, so we believe it to be COVID-19, on top of already existing situations that were pretty bad. We know that in all health crises, it is the poor who are disproportionately affected on account of the limited availability, accessibility, affordability to health services, disruption of existing programs, and that those programs are aimed at addressing inequities, which are really at the heart of some of these diseases. So for those already suffering from some of these poverty-related diseases, epidemics, pandemics, COVID-19 presents what I call a double whammy effect. And this double whammy effect, I like to look at in two ways, as an indirect double whammy and then a direct double whammy. Now, I speak to the direct double whammy in the sense that severity and mortality from COVID-19 or pandemics are strongly associated with nutritional status and age. And these are also risk factors that accompany infections with various groups of neglected tropical diseases or disease of poverty. You may think about neglected tropical diseases and disease of poverty, other infectious diseases causing immunosuppression, which might, of course, increase vulnerability to COVID-19 and other epidemic or pandemic-prone diseases. So the fact is, these entities, these are poverty themselves, present an underlying health issue. Think about the indirect double whammy, also the disruption of routine services, such as mass drug administration for hemophilia, even the manufacturing of drugs and diagnostics and vaccines for other diseases, disruption of poverty-related disease health service delivery, activities like surgeries for Buruli ulcer, the skin grafting cannot go on because of an epidemic or a pandemic, lymphatic filariasis, surgeries, trachomas, surgeries, all these cannot happen because of some of these pandemics. So speaking about a paradox, I like to always refer to Jeffrey Rose's prevention paradox. I remember when I got introduced to Jeffrey Rose as a postgraduate student in Minnesota, I thought at once the public health, if there's anything like that at all. But his paradox, he said it occurs when population-based prevention health measures bring large benefits to the community. Example, compulsory seatbelt wearing, sort of a fat tax or an alcohol tax, or whatever you want to call it, mass immunization, and yet these measures may offer very little to participating individuals. So he proposed that the focus should rather be a moderate risk, because they will contribute the greatest morbidity and ultimately the greatest mortality because of their huge numbers. It's an interesting thought when you look at the world in which we are today, where several actions have been taken supposedly in the interest of the public or in the interest of the publics, which have not gone down very well, even for people who otherwise understand the issues and can make well-informed decisions. And this is what I want to speak to today, some of these paradoxes. But to understand these paradoxes of policies aimed at addressing pandemics, predicting and preventing pandemics, you need to appreciate the heart of it. This is the health inequalities. And these health inequalities really stem from what you can call fundamental causes. And you can think of Lincoln Felon in 95, who put forward the theory, fundamental cause theory, which is really highly applicable in our world today, to these fundamental global political priorities, societal values. And I'll be speaking to this societal values as really one of the spanners in the works, which presents otherwise well-meaning global policies to predict and prevent pandemics as a paradox. The unequal distribution of money and power, and I could go on, but this schematic, I think, brings it out very beautifully. And I hope that the slides will be available online to be viewed later. So because of time, I'll just go on. But I like to say that the absolute version of this prevention paradox, I would say it occurs when there is consensus among the individuals that they do not want to participate in whatever policy measure has been put forward to address a population level concern. And so what individuals do is that they prefer that this measure is not implemented because they think that their individual benefit is really low and they do not care about whatever you may call the population benefit. Think about what happened in the US with the protests against the lockdowns. It also happened in Europe, in Asia, in Africa, and everywhere in the world. It's just a classic example of how some of these measures can be viewed as paradoxes. So should we implement population-based preventive health measures when the typical individual is not expected to gain from them at an individual level, and therefore would not prefer to be subjected to them? How would we deal with mass vaccination against pandemic-prone diseases? Let's talk about COVID in today's world, when we want to reach herd immunity, and unfortunately, a certain percentage of the population say, we don't want it. How are we going to deal with it? And it just speaks to the utility of One Health approaches. And I like to say that pandemic prediction and prevention requires integrated animal and human surveillance systems. Now, when you think of integrated animal and human surveillance systems, you want to think of both the wildlife system, the domesticated animals, then your farm animals in cities, and then the humans in urban and rural areas. And these interact in very, very complex ways. Of course, One Health, one may argue, has been largely focused on zoonotic events, and it's true. Up to about 70% of pandemics, are zoonotic in origin. So maybe rightly so, but it's not limited just to zoonotic diseases. And we also know that the interaction that generated COVID-19, we believe, was generated under larger conditions, which significantly increased not only the risk of cross-species transmission, but also spillover into humans. And Peter, I know that people are really eager to read the report from the WHO on the trip to China that you were on. But we need, therefore, global policies at all levels, global policies at all levels, right at the level of the response interventions, which are in the early epidemic phases. We need to be able to do the prediction, which is to anticipate and to detect early. And then we need to do the containment, the control and mitigation. And that's exactly what Jono spoke about so beautifully when he projected us into 2035. If we're able to put in place global level policies that can fix the problem at every single level. I'm eager to find myself in 2035. I think I'm fairly young to believe that I should be around, alive and kicking, strong and healthy by 2035 to see Jono's prophecies come to pass. I'll go on and speak to this report, but I could speak directly about some of these global policies. There's a myriad of them which have been proposed, and I don't need in this forum to speak specifically to some of these policies, but just to point out some of the inherent complexities in putting forward these policies and in actioning them. So I recommend this as a really great read. The IPBES report on biodiversity and pandemics really speaks to the relationship between biodiversity and pandemics and proposes very, very cogent solutions along with what others have done in other work. I strongly encourage you to read this. So I'll not go into some of the details of that because that would take us forever. But just to say, what can we really say about prediction and prevention policies? What can we say? And I really apologize for this, but the right side of the slide is supposed to be what can't we say. So do pardon me, the can't did not come. So the left of your screen would be what can we say? We can say that prevention is cost effective. This is clear. Ultimately, if you value human life, and we argue that we really cannot put a dollar sign to human life, although the economists would argue otherwise, then you would conclude automatically that a lot of prevention is cost effective. Then a lot of prevention upstream that is tackling what I call the fundamental causes, the poverty and the inequities, the inequalities, is cost effective and will reduce these health inequalities and therefore shift the whole curve as we speak about, or as Jeffrey Rose talked about. But what we can't say is that prevention will necessarily lead you to cost savings. So there's a difference between cost effective and cost savings. It really is the premium that you put up on that. And we also cannot tell precisely what the best buys are. And I'll explain why I say we cannot say precisely what the best buys are. And I'd just like to go on and speak directly to what I call some of these paradoxes. The picture that you see on your top right is actually a picture that was taken just this weekend. My team was out in the field doing a seroprevalence study here in Kumasi, Ghana. We're going to do the same also in the capital city, Accra. So you see our nice looking hard body 4x4 and some of my staff out there interviewing people, taking blood samples, bringing it back to our labs right here where I sit to do the ELISA test and check. Now, this is fairly well received today because we are in a pandemic situation. But if this was to be some routine surveillance when there was no problem going on, you can imagine the resistance that people would put up. Why are you coming into my home, wanting to take 5 mils, 10 mils of blood, saying that you're just on the lookout for something that could affect everyone in the world? Why me? I don't want to give my blood. So we need to answer very complex questions. And these complex questions require a lot of multidisciplinary efforts. And I like to say very, very bluntly, the more successful we are, the weaker arguments for policies that are calling for investment and population level interventions. When I say the weaker arguments are, I'm talking about what comes across intuitively to decision makers and even to the general public. Why spend money when we don't see a problem? It's always a conundrum we face. The absence of the problem suggests that the global health or the public health is working well, but then it comes back to bite us. There's also variance in value systems globally. And this makes putting forward global policies for prediction and prevention a huge challenge. This is because we need to generate consensus sometimes on who the risk groups are. Why do you say this group is at risk? Population in Africa largely young, and so we don't think the elderly are particularly our focus because they don't form the majority of the population. It will be quite different, say in Japan or in Switzerland, for example. So this is also a challenge. which policies should we put forward to protect these risk groups if we even manage to agree on them? And how do we action these policies? So these are also the paradoxes. We all have the end goal in mind. We agree that there's a problem, but in putting forward these policies, we face many, many paradoxes. And I just want to share this as I conclude. I'd like to refer to this as a tide strong enough to lift all boats. And the question is, these global policies, will they really take us where we want to get to? And is it fair and equitable to everyone? Just yesterday, Ghana, where I sit, was the first country in the world to receive the COVAX vaccines. And they came in yesterday, 600,000 doses of the AstraZeneca. There's a lot of fanfare, a lot of celebration all over the world. But the question is, 600,000 doses for about 40 million people? Well, we know there's more going to come, but it just tells you that the COVAX policy, for example, is the COVAX arrangement is catering for 20% of the burden in all countries that have signed up for it, which means that the countries need to find a way of getting the rest. Fair enough. But it just tells you that some of these global policies may be great, but they may not really take us there. What do we need to do to address some of these policies, which are good, but if we don't push them far enough, they become an exercise in futility and do not take us there. And this really speaks to issues of equity and solidarity, which we need to highlight. CEPI, Gavi, Vaccine Alliance, Predict, and all these other groups really before COVID were in place to address some of these issues of equity and solidarity. You may want to think about, even as you think about individual level benefit versus population level benefit, even within the populations, is it a benefit to a particular country in Africa or the whole African continent? Is it the whole African continent or the whole world? So there's so many complexities in there, which create all kinds of paradoxes. And I'll just conclude with two slides. One, again, is this IPBES report. And in that, we do make some recommendations. We speak quite boldly about the possibility of launching a high-level intergovernmental council on pandemic prevention. That would be a really interesting prospect. It will be complex to do, but we think it's time to do this kind of thing. And I do encourage you to read that report and study the arguments we put there. Together with colleagues, I also authored a short correspondence in the Lancet where we called for a COVID-19 One Health Research Coalition. Now, this is not focusing on COVID-19 per se, but just using the backdrop of COVID-19 as really a turning point in the history of the world to call for a One Health Research Coalition, where we would team up with climate change, planetary health folks, the general international community in designing, undertaking, and coordinating, synthesizing research, which is aimed at promoting a healthy and sustainable planet. And with that, I'd like to say thank you for spending time to listen. We'll be happy to take any questions after the final presentation. Thank you.
Thank you very much, John.